In my presentation, I will summarize how to select the best imaging modality in each case of the uveitis. And we will try to learn at the end of this presentation how we can select the best imaging approach for the cases of the posterior uveitis. So as we know, when we say a posterior uveitis, we are talking about the posterior part of the eye. We are talking about the retina, including the macula, the optic nerve, the retinal vascular circulation, the choroidal circulation, and also the sclera. And also we should not forget to focusing on the superficial plexus and the plexus at the foveal area. And when we want to go for the classification of the imaging in posterior uveitis, we have to keep in our mind, we have always two options. When we have an opaque ocular media, like the dense cataract or the dense corneal opacity, the only option will be the B-scan. While when we have a clear optical media, we can get a wide range of imaging like the fluorescein, ICG, fundus autofluorescence, and OCT. The first imaging modality, as we know, is the fluorescein angiography, which is the serial of fundus imaging, usually taken after the injection of the intravenous fluorescein dye. And the good thing about the fluorescein, it's very useful in the cases of the posterior uveitis, whether infectious or non-infectious. The first advantage of the fluorescein, we can identify the optic nerve inflammation. Usually we can see it in the form of early hyperfluorescence with a late staining and leakage. And this is a non-specific sign, but is very helpful for us as a sign of the activity of the posterior uveitis. The second finding and the importance of the fluorescein is the detection of the macular edema, which is one of the causes of the drop of vision in the cases of the posterior uveitis. And the typical finding on the fluorescein angiography is the flower petal hyperfluorescence pattern. Usually we see it on the back, especially at the macular area. But the major advantage of the fluorescein angiography is the detection of the retinal vasculitis, whether the involvement of the arteries, veins, and also the complications of the occlusive vasculitis, like the ischemic maculopathy or the peripheral areas of non-perfusion. And this is quietly important because to limit the differential diagnosis of the posterior uveitis, such as in this case, in which the occlusive vasculitis involving predominantly the retinal arteries, we can limit the differential diagnosis to the short list of the diseases like the SLE or the polyarteritis nodosa or the infectious causes like the herpes or varicella zoster. And in the cases when we got an occlusive vasculitis, which is a predominantly retinal phlebitis, we can also short the list of the differential diagnosis to the infectious causes like the toxoplasmosis or HIV or cytomegalovirus retinitis, or even the non-infectious causes like the sarcoidosis. And when we got the occlusive vasculitis of the arteries and veins, in this case, we can think about the Paget disease or the Wegener granulomatosis. The wide field fluorescein imaging is also very useful for the detection of the complications of the occlusive vasculitis, like the peripheral retinal ischemia and also the complications of NVDs or NVEs, neovascularization elsewhere. One of the advantages also of the fluorescein angiography is the detection of the active versus inactive inflammation. As we can see here, this is the active focus of the toxoplasmosis versus inactive focus of the toxoplasmosis. And also it is quietly useful for the detection of the complications of the retinitis, like the development of the CNV. And also the final advantage is that the fluorescein angiography in some cases, it will be very helpful to see the exudative retinal detachment in many cases, like the Vogt-Koyanagi-Harada or the sympathetic ophthalmitis. Also, the fluorescein angiography is a very useful in the inflammatory diseases that involving the outer retina, the retinal pigment epithelium, and the choriocapillaris. And we can see here in this patient with acute multifocal posterior placoid pigment epitheliopathy, we can see the multiple whitish creamy lesions that usually seen on the fluorescein angiography in form of the black hypofluorescent spots in early phase, and then hyperfluorescent spots in the late phase because of the staining. And again, in the serpiginous choroiditis, the same thing, we can see the lesion widely visible on the fluorescein angiography in a form of the early hypofluorescence due to the blockage effect, and then the late hyperfluorescence because of the staining. So in summary, the fluorescein angiography is very useful for the detection of the optic nerve inflammation, also the detection of the macular edema, and the detection of the retinal vasculitis, whether arthritis, phlebitis, or both, and the differentiation between the active and inactive form of retinitis. And also it is very useful in the inflammatory diseases of the outer retina and the choriocapillaris. Now, the next imaging modality is the ICG. The interesting thing about the ICG is we inject the indocyanine green dye, and this dye will not leaking out the choroidal vessel. So this gives an advantage for the ICG for a better visualization of the choroidal circulation, and which is a very useful tool when we want to look for any inflammation in the choroidal vessels. So what is the difference if we put the ICG versus the fluorescein angiography? If we look to the left picture, this is the fluorescein angiography for the patient diagnosed with a sarcoidosis. And the patient was complaining from the drop of vision in his eye. Fluorescein is quietly normal. But when we look to the right image for the same patient of the ICG, we can identify the area of hypocyanism. This is the black area caused by the sarcoid granulomatous inflammation. So the ICG, it can reveal many changes that cannot be seen by the fluorescein. This is again the another image for the patient with the Voca Unake Harada. And when we look to the left picture, this is the picture of the fluorescein angiography. And just we can see the hyperfluorescence of the optic nerve. But when we look on the right side, the ICG, we can see the tremendous changes in the choroidal level and these areas of hypocyanism due to the choroidal inflammation and the choroidal ischemia. And again, in the cases of the serpiginous choroiditis, this is the case of patient with serpiginous, and this is the fluorescein. Then we can see the serpiginous lesions usually take the form of hyperfluorescence. But when we look to the ICG, we can see that these lesions actually are atrophic lesions, and we can see at the same time unmasking of the choroidal vessels. So the changes usually reflected by the ICG, it's not always the changes that we see on the fluorescein. So the message from the ICG, if you got any inflammation or you suspect any inflammation at the choroidal level, the best imaging modality is to do the ICG if it is available in your country. The other imaging modality, which is very interesting and is non-invasive and very informative, it's the fundus autofluorescence. And just to give a short detail about this image, the fundus autofluorescence, it's an imaging modality which depends on the lipofuscin, which is found in the retinal pigment epithelium, and it is a byproduct from the digestion of the outer segments of the photoreceptors by retinal pigment epithelium. And it will depend on the fluorescence of the lipofuscin. And in the normal fundus autofluorescence image, we look to the macular area, usually black, because there is no lipofuscin there. And also on the optic nerve, it's usually black. And the retinal vessels is also black because of no lipofuscin. And I will show you why the fundus autofluorescence can be very useful for us. This is a patient with a serpiginous choroiditis. We can look to the picture of the right eye and the left eye. And you can see many serpiginous lesions across the fundus. The question is whether these lesions are active or not. Sorry. When we do the fluorescein, fundus autofluorescence, we can see these hyper-autofluorescent lesions here. These lesions usually the indication of the active lesions. And at the same time, if you look to this lesion, this is the lesion of the hyper-autofluorescent lesion with the hypo-autofluorescent rim, with a blackish rim. This is the healing lesion. So if I want to take the decision on this patient, whether to treat him or not, and I was unable to do the fluorescein angiography for him, I can go for the fundus autofluorescence and performing a non-invasive imaging modality, and I can differentiate whether these lesions are active or not active, and I take the decision for the treatment. Also, the fundus autofluorescence is very useful in the cases of the infectious uveitis, like in the cases of the TB. Like in this patient, we can see in a fundus autofluorescence, the active lesions usually are hyper-autofluorescent. And also in this case, this is also the patient with a TB choroiditis, and I want to take the decision whether I should treat the patient or continue the treatment or not. And when I do the fundus autofluorescence, I can find that still there is a hyper-autofluorescent lesion, which lesion indicate that the disease is still active and I need to treat the patient. Now, the OCT is another image modality, and I think it is one of the revolutionary imaging modality, and it can give us a very nice details of all the layers of the macula. And again, what is the advantage of the OCT? It is a very informative, non-invasive cross-sectional imaging for the macula. So when we have any disease involving the macula, or we want to monitor any complications of the macula due to the posterior uveitis, the best imaging modality is the OCT. And from the OCT, we can get many informations, like we can look for the cystoid macular edema. We can look also to the epiretinal membrane. We can also look to any abnormality of vitreoretinal interface, like the vitreomacular traction. And also we can look for the presence of any vitritis. Now, one of the useful tools of the OCT in some cases is the 3D OCT. This is one of my cases, the patient, renowned case of Paget with a dense cataract. The patient, he got the anterior uveitis, and I was not able to see the posterior segment. So we did the swept source OCT for him, and this is the 3D image. And you can see with the 3D the extensive degree of vitritis. And this is just the image after the receiving of the pulse therapy and the oral steroids after 1 month. And you can see that's quite improvement in vitritis. Still, there is a hazy view because we cannot see the fundus because of the cataract. So the next imaging modality was very useful and very revolutionary for our clinic is the swept source OCT, because in the swept source OCT, you can see all the layers of the retina very nicely. You can see the vitreous, you can see the retina, you can see the choroid, and you can see the sclera. And actually, this is a very important, we will see in the next cases. Now, the typical finding in Voke Unagi Harada in the ordinary OCT is looking to the OCT, we can see the multiple areas of the neurosensory detachment, like the multifocal neurosensory detachment. This is a very typical finding in a patient with VKH. And when we look to the VKH from the swept source mode, we can see that there is not only the matter of the neurosensory detachment, there is a huge increase in the thickness of the choroid. And once the disease is treated, after the treatment, we can see that the choroid usually return to the normal thickness. And once we got the early recurrence, we get the increase in the choroidal thickness again. And this is a very important tool when you want to monitor your patient with BKH after the treatment, and you want to be sure that there is no any recurrence of the disease. You can just do the swab source OCT and look into the choroidal thickness, because the normal OCT, this doesn't mean that there is no disease activity. You are just looking to the head of the iceberg. The other advantage of the OCT is the OCT can identify sometimes the atrophic changes at the macula because of the chronic posterior uveitis. Now, if you look to the image, the color fundus image, this is the patient with birdshot retinopathy complaining from a drop of vision in his right eye. And if you look to the macular area, it's quietly normal. And when you look to the OCT, you can see that there is a destruction in the photoreceptor layer and the external limiting membrane. And look to the thickness map, there is a tremendous thinning. So another advantage of the OCT is the detection of the destruction effect caused by the posterior uveitis. The other tremendous tool, a very useful tool, is the OCT-A. The OCT is one of the newest imaging modality, which depends on the tracking of the moving red blood cells in the superficial and deep plexus. Just to know where is the superficial plexus, it is found just at the level of the ganglion cell layer and the nerve fiber layer, while the deep plexus, it is located in the inner nuclear layer and external plexiform layer. And what the advantage of the OCTA is the visualization of these layers, especially the deep plexus, which cannot be seen by the fluorescein angiography. And the OCTA, I will show you how it's useful in some cases of the posterior uveitis. This is one of my patients. It's a 39 years old female, medically free, presented with a sudden drop of vision mainly in her right eye. The vision was 0.1 in the right eye and the left eye was 0.7. The anterior segment examination was quietly normal and the posterior segment examination was completely normal, where there's no evidence of vitritis. I asked the patient initially to do the OCT as a non-invasive imaging modality. The patient at that time, she refused. She went to the public sector and she did the fluorescein angiography. This is the false color image of the Heidelberg for the fundus. This is the fluorescein angiography. And if you look carefully to the late phase, you can see here that there is a perifoveal vascular staining. But this is the right eye and this is the left eye. But again, this perifoveal vascular staining, which is a sign of the perifoveal vasculitis, doesn't explain the severe drop of vision in the right eye. We may find some increase in VAS in the right eye, but it does not go with the drop of vision in the right eye. So at this point, I decided to do the OCTA. And this is the finding of the OCTA. And you can see very nicely the huge ischemia involving the superficial plexus and the deep plexus. And this is the retinal density map. You can see the ischemia in the blue area. This is in the right eye, and this is in the left eye. And this gives a perfect explanation why the vision in the right eye 0.1, while in the left is 0.7. So at this moment, we did the general investigation to exclude any infectious causes, and we decided to treat the patient with pulse therapy and the oral steroids, as it is a case of the perifoveal retinal vasculitis. And this is the after the imaging after the 2 weeks of the pulse therapy and the oral steroid. And you can see the vision improved in the right eye from 0.1 to 0.7. And the ischemia quietly improved after the treatment with a macular reperfusion. And in the left eye, the vision was 0.7 improved to 1. So this is one of the applications of the OCTA in the cases of the posterior uveitis. What about the D-scan? as we mentioned in the beginning of the lecture, the B-scan, it's a very useful tool when you got an opaque ocular media or a hazy optical media like the corneal opacity, or you get a cataract. Very useful to identify any retinal detachments, also to detect any tractional membranes, and in the cases of the posterior scleritis, like we can see that, and also to detect any intraocular tumors, like any hidden tumors. We call them masquerade syndrome. So this is about the B-scan. So before I finish my talk, just I want to present to you the last case. This is a 45 years old male, medically free, presented to my clinic with a bilateral gradual drop of vision of the 8 months duration, starting in the right eye and then involving the left eye. Now, the best corrected vision in the right eye was 20/100, while in the left eye was 20/40. The anterior segment examination was negative, no any signs of anterior uveitis. The posterior segment examination, no vitritis. The fundus, you can see the bilateral subfoveal yellowish lesions with some RPE changes. So I decide at this time to do starting with non-invasive imaging like the OCT, and again the OCT showing the subfoveal hyperreflective material in the right eye, and in the left eye also the same. I usually I need to differentiate whether this is a case of posterior uveitis or not. So I take the one-line HD image, and I found that there is an increase in the choroidal thickness, which is around 600 here and 613 in the other eye. The question is, what is this case? This is a case of the posterior uveitis or something different. So before I go to any invasive imaging modality, I did the fundus autofluorescence. And surprisingly, when I did the fundus autofluorescence, I can find very nicely gravitational tracts on the both right eye and the left eye. One of the typical findings of the chronic central serous retinopathy. But to be sure, because the treatment approach in both cases, it's not easy, because it could be a case of posterior uveitis versus a cases of chronic CSR. And one of the differential diagnoses in my mind at that time is the Parade disease, in spite of there is an absence of the optic disc edema, but it could be an early case of Vogt-Koyanagi-Harada. So I did the general investigations to exclude any inflammatory causes or infectious causes. It was negative. And I did the fluorescein angiography just to confirm my diagnosis. And again, the fluorescein angiography showed to me that this is a case of the chronic CSR. So we decide to treat the patient. I treat the patient with a micropulse laser with anti-VEGF. And this is the OCT before and after the treatment, with improvement of vision from 20/100 to 20/30 in the right eye, and the left eye from 20/40 to 20/25. So my message from the last case, in any case of the posterior uveitis, try to reach the case with a multimodal imaging approach. Try to select the best imaging modality, and usually start with a non-invasive imaging modality. Thank you very much, and Ramadan Kareem.
Thank you very much,
Dr. Mohammed. Yes.
Thank you very much. It was very illustrative lectures, and the role of multi-modal imaging in uveitis especially is very important and crucial from both aspects, financial and from the patient, because maybe you ask for many investigation tools, and this is maybe you exist your patients, but really you can take or select one of the investigation that can help you in targeting the diagnosis. So thank you very much. It was amazing. We will start to have take questions from our attendee. We will start by Dr. Ahmed Yahya.
Yes.
Dr. Ahmed.
Thank you very much, dear Doctor. Really, it is a very nice lecture. My question from the last case you presented.
Yeah.
Is it a subretinal neovascularization or something else?
No, it is not. Yeah.
Does the anti-VEGF is effective for CSR or not?
Okay. Thank you very much. Actually, it is not our subject today, but I will answer your question. So I did the OCTA. It was not no CNV because we can find cases of chronic CSR CNV. It was not any no CNV. Regarding the anti-VEGF, yes, I had a good experience about the using of anti-VEGF in the cases of chronic CSR, and it really worked. Actually, I usually prefer to use the aflibercept for them just to dry the fovea, and then I stabilize the disease by giving the micropulse laser. I usually use the yellow micropulse laser and give the patient one session, and in most of the cases, the condition completely resolved.
Thank you very much.
You're welcome. Okay, Dr. Mohammed, any questions, further questions?
Dr.
Mohammed?
Yes, yes. I can hear you. Dr. Magdi,
yeah.
With us?
Assalamu alaikum. Thank you very much. I have two questions, please. Can OCTA replace the job of indocyanine green regarding choroidal circulation?
Yes. Okay, thank you very much. Now, the OCT, especially the swab source OCT, will be very helpful for you in some cases, but not in all the cases. For example, in cases of Voca-Unagi Harada, if you have no access to the ICG, you can use the swab source OCT to look to the choroid. But in many cases, the ICG is more sensitive than the OCT. Even in the cases of Voca-Unagi Harada, the recurrent cases, they studied a group of patients, and in some recurrent cases, they found that the choroidal thickness at the macular area was not increased. However, the disease was active. So the ICG, yes, it is more sensitive and better than the OCT in any cases of inflammations involving the choroid. But in my clinic, I have no access to the ICG, so I depends on the swab source OCT in follow-up of the cases of VKH to detect any recurrence of the disease.
Okay, we have a comment from Dr. Abdulaziz Badla. You want to add a comment, Dr. Fawad?
Yeah.
Abdulaziz.
Yeah, thank you, Doctor, for this nice presentation. And I still have a question about giving the anti-VEGF in this case. Either we couldn't find any CMV, that even in the chronic CSR cases, in my knowledge, that if there is no definite CMV, there is no role for the anti-VEGF. So,
okay, thank you, Doctor. But actually, there is many papers talking about the role of the anti-VEGF, and especially the Avastin or even the aflibercept or the ranibizumab in the cases of the CSR. I usually facing many patients with a chronic CSR, which is the main challenge for us. And usually we treat them with the anti-VEGF, and some of them are quietly responding very, very, very beautiful to the anti-VEGF. But in a chronic cases, you know that you need to use all the treatment modality aspects to treat the case. In this case, the patient was a dentist. He was not an easy patient. And before I start with micropulse laser, I gave him the one injection of aflibercept to reduce the subretinal fluid. Then I will start after 2 weeks with giving the micropulse laser.
So, Dr. Fawaz, can I ask you regarding this case?
Yeah.
You go for this case for OCT angiography, and you cannot detect any CMV, right?
Yes, sure. I didn't show in my presentation. I did the OCT. I almost do all the image modalities for my patient because at the end we need to find out the diagnosis.
So-
This case, by the way, was not an easy case. And the good thing about this case and the crucial thing was the fundus autofluorescence that makes me to suspect that this is a case of chronic CSR. And just to explain to the audience,
Yes.
that some of the audience may ask why the choroid was thick in this case and why we should not suspect any case of posterior uveitis. This is correct because in the chronic CSR, the choroid is thick. It's one of the pachychoroid disease. So that's why sometimes one of the differential diagnosis is not easy. And that's why we need a multimodal imaging modality to be very helpful for us. And in this case, the fundus autofluorescence, was a non-invasive, very useful tool to reach the diagnosis.
I'm with you with that, but we need to, because this area, the era of giving anti-VEGF to a CSR is very important. We see a lot of maybe ophthalmologists giving anti-VEGF in acute cases of a CSR.
No, yes, I totally agree with you. You should not give any anti-VEGF in acute cases.
Okay.
But however, it's not in some patients may insist about the improvement of vision. So you need to follow up them and reassure them, which means when I face the patient with acute CSR, I will not let him 6 months. I will repeat the OCT after 1 month, and we will monitor the improvement of the subretinal fluid.
Yes.
And then I will assure him that everything is okay.
Yeah, it is very difficult case to diagnose. You are right, doctor. But
Yes.
you know that you didn't try all these microballs for this case. Maybe also it succeed, and you know also the classic treatment for this case is the BDT. I know they have dose of BDT, but I still insist that giving the anti-VEGF even in the chronic CSR cases, if there is no definite CMV for me.
No evidence-based, Dr. Abdulaziz. No evidence-based.
Yeah.
Yes.
But I am agree with you. This is a very difficult case to diagnose, and maybe if you try all these microballs, you will get the same results.
I usually try to dry the macula as much as I can in order to reduce the power of the laser and to be more effective.
No,
because the micropulse laser, it's not an easy tool, and you know that you need a wide range of experience. Unfortunately, I don't have an access to the photodynamic therapy in my clinic. That's why I shift to the micropulse laser. And sure, in many papers showing that the photodynamic therapy results is better than the micropulse. But in advanced cases, still there is a place even without CNV for the anti-VEGF. Thank you very much.
Thank you.
It's debatable. It's still a big debate in all, It's in all conferences when you're talking about the role of anti-VEGF in the cases of
Any question from the audience regarding anything is not clear regarding the imaging modality? I am happy to answer.
One question from Dr. Galaxy.
Yeah.
Doctor?
Assalamu alaikum. My question is where to aim the micropulse laser and what are the parameters?
Okay, it's not our subject, but I will answer you. Okay, first of all, the micropulse lasers need a long learning curve, but there is a two-way to set the power of the micropulse laser, which is the most important. Either you put your laser in a micropulse mode and you're firing the laser on the retinal periphery, and when you just reach to just a blanching effect, you reduce the power to the 50%. Okay, and this will be the power for the laser. You should keep the same size, and the 5% duty cycle. This is the first way. The second way is to put the laser first in a continuous wave mode, and you fire at the periphery of the retina. And once you find the blanching effect, you will triple the power. For example, you find the blanching effect at the power 50, so you put it 150. But the power should not be more than 300, which means if you found the power, for example, 150, when you fire the periphery, So it should not be 300 or 450. It should be maximum 300. And you should targeting the leaking point only. So you're firing on the leaking point, not firing on the areas without leakage. I hope that will answer your question.
Last question from Dr. Ahmed Juma. Dr. Ahmed Juma.
Assalamu alaikum.
Alaikum assalam.
Thank you, Dr. Muhammad. How are you, Dr. Fawaz?
Hi.
A nice, informative presentation. And I have the same case like you with the chronic CSR. When I did fluorescence angiography, you find multifocal of leakage, especially near the optic disc. So I give him a chance of prednisolone tablet and some resolution, but not so much. So you advise for micropulse laser for those patients with uveitis with the chronic CSR, and which machine good for micropulse laser, and if there is a photodynamic therapy in Jordan, there is a present or not? Thank you.
Okay, so first of all, just to put the question in this way, how to differentiate between the cases of posterior uveitis versus non-uveitis, as in shown in my case. It's very important to get a multimodal imaging to reach your final diagnosis. And in this case, if I suspect that this is a case of posterior uveitis and I give him the steroid, this will worsen the condition and will cause more drop of vision. But when I look carefully to the multiple imaging modality and to the fundus autofluorescence, I found that this is not a case of posterior uveitis. So I confirmed the diagnosis by doing the further investigation and also by the fluorescein angiography, and I found this is a case of CSR. So if you have an access for the photodynamic therapy, it is much better than the micropulse laser. But in Jordan, the photodynamic therapy is not available now. And we go for in those cases, in a different approach. For me, I have a good experience with a micropulse laser. I usually use micropulse laser. Some of the colleagues may using other modalities, giving the spironolactone or giving the methotrexate also, different modalities, because it is still a debatable subject. And each retina consultant has its own way of treatment of the chronic CSR based on his experience.
Okay, thank you.
Last question again from Dr. Magdi Afif. I want to ask you again, Dr. Fawaz.
Yes, welcome.
Excuse me. My question, can you highlight fundus autofluorescence test and how to interpret it?
Sorry, I didn't hear the question.
Regarding fundus autofluorescence,
how
to perform and interpret it.
Okay, so I will return back with my slides. Okay, so the fundus autofluorescence, it's an imaging modality that depends on the lipofuscin, which is found with the retinal pigment epithelium. And this lipofuscin, it's a waste product of the digestion of the retinal pigment epithelium to the outer segments of the photoreceptor. And with this imaging modality, we're looking to the fluorescence coming from this lipofuscin, and due to the accumulation of the lipofuscin within the retinal pigment epithelium. When we look to the normal fundus autofluorescence, like in this image or in this image below, the areas that usually seems to be black, like the macula, the optic nerve, and the retinal vessels, usually it appears black because there is no any lipofuscin there, okay? And also we got a masking effect of the xanthophyll pigment over the area of the macula. So when I look to the fundus autofluorescence, I will not see any area of hyperautofluorescence. Now, in diseases like the uveitis, as I shown in my cases, like the cases of serpiginous choroiditis, when we got the inflammation of the choroid and the RPE, because the RPE is affected, so the lipofuscin will accumulate more, and this will causing the hyperautofluorescence. And this is very useful for me to detect whether the lesion is active. And at the same time, I can also get an advantage whether to detect the healing lesion. Like in this, in the same case here, this lesion, if you look at it, is different from this lesion. This lesion is hyperfluorescent with hypofluorescent edges. This is a healed lesion, while these are the active lesions. So the fundus autofluorescence is very useful to give me an information about the disease activity and whether should I continue with treatment or not. The same thing for the case that I showed in the case of TB, because we are facing many TB in the Middle East and also in some areas in different countries like India. And sometimes we need to take a decision whether we need to continue with the treatment or not. So I don't need to ask the patient to do any invasive treatment. So just with the fundus autofluorescence, for example, if I want to look to this lesion, whether this lesion is active or not. So when I do the fundus autofluorescence, I can see there's a hyper autofluorescence. So this is a quietly active lesion. When I look to the patient below, we can see the extensive lesions all over the fundus. And I need to know whether this lesion is healed lesion or active lesion. Just look to the fundus autofluorescence, and you can see that there is area of hyperautofluorescence here, which indicate that the disease is active. So I need to continue with the treatment.
Okay, thank you very much, Dr. Fawaz. It was a very nice illustration for the role of multimodal imaging in uveitis. We don't have any more questions, so thank you very much for your participation.
Thank you very much.
Yes, thank you very much. Now we reach to the final presentations in our meeting today. I would like to welcome Dr. Ahmed al-Janabi, and this is actually the advantage of Zoom. I know Dr. Ahmed al-Janabi through our attending to same meeting, and Dr. Ahmed al-Janabi is a retina fellow. He have a good experience in uveitis. He was a fellow of Moorfields Eye Hospital, London. He spent 4 years with a consultant uveitis there. Dr. Ahmed, مساء الخير.
مساء النور دكتور محمد. Can you hear me?
Yes, I can hear you very well. And as I told you early in the conference, Dr. Ahmed now in his duty in the hospital. So
yes. 15 minutes left.
Okay. Welcome, Dr. Ahmed. All of us
Thank you.
wanted to you take us to a special journey with how to think uveitis.
Okay. I've started sharing the slides. Is it available to all of you? Is it visible?
Visible and clean. Go.
Excellent. Okay. So thank you very much for the invitation, Dr. Muhammad, and also to thank my colleague for listening to this webinar. And special thanks to Dr. Noor Al-Qasimi, and who has always been very supportive and helpful. So my talk is about how to approach a case with uveitis. I'll take you back to the basics.
طبعا دكتور احمد please can I also give a special thanks to دكتورة نور القاسمي because she is يعني هي اللي كانت السبب انه عرفتنا على بعض. I would like to give her special thanks. She's my prof, and thank you so much for her.
That's very true. I always believe that wonderful